Hi, my name is Eric Weiner, and I'm here for Blood Cancers Today. I am a assistant professor at Harvard Medical School and the clinical director of adult leukemia at Dana-Farber Cancer Institute, and I'm here with two outstanding colleagues and friends, and we're going to have a discussion about AML.
Hi, my name is Yasmin Abaza. I'm an assistant professor of medicine at Northwestern, specializing in AML and MDS.
Hi, my name is Naval Daver. I'm a professor in the Department of Leukemia at MD Anderson Cancer Center, Houston, Texas, and looking forward to this discussion.
So, as just from some simple background, we are all fully aware that AML is a disease that we consider an unmet need, and it affects about 20,000 people each year in terms of the incidence, and about 11,000 to 12,000 deaths each year. And what's really important that we've learned is how age plays a very big role in patient survival, whereas patients under the age of 40 might have a 50%, 55% survival. Patients in their 60s, that goes down to about 15% 5-year survival, and then past that, in the 70s and older, it tends to be about 4% 5-year survival. So just if I can start with Dr. Abaza, when a younger person, and you can define young how you wish, but when a younger person comes into your office, how do you think about treatment, and what's your algorithm in terms of how you treat that person?
It's a great question. So we look at a couple of things from a patient's perspective. It's not just age, but also comorbidities, overall performance status to determine fitness. We also look at the fitness of the disease itself, so looking at the molecular characteristics and cytogenetics to determine how to best manage. For the majority of patients, we, of course, have to look if they have a targetable mutation. We look at our clinical trials and what we can offer them. And depending upon if they have particular, like FLT3, IDH, NPM1 mutations, we may gear towards an intensive chemotherapy-based approach with either a targeting inhibitor, like a FLT3 inhibitor, or if we have a clinical trial like menin inhibitors, we would do that. However, there's some categories where we would not do intensive chemotherapy, even if patients fit, like biallelic loss of TP53, where even if they're fit, the data doesn't show that intensive chemotherapy is better than a less intense regimen, and we would go with either a trial or less intense regimen. So it's a complicated algorithm that we take into account the disease in addition to the overall performance status of the patient.
Dr. Daver, what's the approach at MD Anderson?
Yeah, very similar actually, and we have many trials actually that are open at both Northwestern and MD Anderson. So yeah, frontline for newly diagnosed, we're looking for FLT3 mutations. If we see a FLT3, we are usually going with a FLT3 inhibitor. Today, quizartinib is a FLT3 inhibitor that we're using more based on the recent Quantum First data and tolerability experience with that. For the others, we usually will be checking for core binding factor and APL. Of course, those are going on separate clinical trials or regimens. And then we do look to see if patients have a menin, MLL rearrangement or NPM1 mutation. There are now clinical trials, it's not standard practice, but trials that are incorporating menin inhibitors in the frontline setting, both with intensive chemo, low intensity. So if I find a KMT2A rearrangement or an NPM1 mutation, then I would be prioritizing those trials. And then for the rest, depending on, and I think this is a good point that you brought up about age and fitness. And I think this is moving quite a bit. About 5-6 years ago, it was really above 75, 70. But today, above 65, we're starting to think about low-intensity therapies. There may be exceptions like core binding factor isolated NPM1, where maybe you will still do intensive. But for the majority above 65, I think we're moving with low-intensity therapies, either aza-ven or maybe even combinations adding to aza-ven, a FLT3 inhibitor, menin inhibitor, such. So I think that's kind of the general landscape. The big question now, I think, is revolving around MRD and how we can use that maybe down the line with whatever treatment you started to decide if a patient needs transplant or not. For example, NPM1, FLT3 molecular clearance, there's data emerging that some of these patients may not need transplant absolutely, and then also post-transplant who may need maintenance or not. So I think that's really now the area that we're trying to see if we could avoid transplant or stop therapy in certain patients using MRD in the future.
Yeah, and I think we take a very similar approach between intensive versus non-intensive. I think what's really exciting is that we have, and I think both of you touched on this, the importance of clinical trials in this particular setting. As well as we are doing, and we talked a little earlier about how we're really making strides over these past 5-7 years, we still really aren't satisfied with the results that we're getting, and therefore these clinical trials are extremely important in trying to figure out how we can best improve outcomes. But we take a very similar approach in terms of intensive versus non-intensive based on the molecular aspects, by the genetic data, and the fitness of the patient.